and thanks for the invitation to be here today. I'm very happy to be speaking to all of you. So my goal today is to talk to you about, or get you excited about, interpretable AI models, and talk a little bit about our own research in this space, meanwhile, doing that. And I want to just start by a quick advertisement. So we are organizing the middle conference, Medical Imaging with Deep Learning, this coming summer in Salt Lake City. I'm one of the general chairs, along with Drs. Elhabian and Dr. Summers. So this is the 8th iteration of this conference. It's going to be the 3rd time it's in North America. So we very much look forward to seeing you there. If you are working in the space of deep learning and medical imaging, this is a great place to be if you are a researcher or if you're a company in this realm. The call for papers is out. The deadline is going to be in January, and the conference is July 9th to 11th. So if you're interested, please check out the website. Okay, and before I get going, I also want to say a few words of acknowledgements. So the work I'm talking about today was funded by the NIH, and it's by a group of interdisciplinary people ranging from machine learning, AI, to radiology, bioinformatics, and psychology. The majority, almost all of this work was done by my PhD graduate, Ricardo Lanfredi, who's now a postdoctoral researcher at the NIH, so the credit goes to him, not me. Okay, so I want to start by asking this question: do we need interpretable AI models in radiology? Because certainly there is one point of view which says like rigorous evaluations of model accuracy statistically should be sufficient. If AI we can show is consistently more accurate than human doctors in diagnosing disease, then we can also reason that it's safer. To proponents of this point of view, can give an example, for instance, from pharmaceutics, where it can point out that a lot of drugs, commonly used ones, in fact, we don't completely understand their mechanism of action, but through rigorous evaluations of safety and efficacy, we have widely adopted using them. So I want to make the opposite case today, that there is a need for interpretability in radiology, and it's a little bit different than pharmaceutics because of several reasons. So first of all, we want to build clinician trust in our models. If we don't, then our models are going to be getting slow in getting adopted into clinical use. So when your AI model tells a doctor that lung nodule in a chest X-ray is suspicious to be cancer, it's more trustworthy if there's an explanation behind it. We train our models, for instance, chest X-rays with the easiest obtained ground truth usually. So these are typically labels that we mine from radiology reports, and we do image level weekly supervised training. There can be spurious correlations, for instance, that confounders in our model. We might be looking for pneumothrax, but we might be seeing something that co-occurs with it a lot, like a drain tube or something of that nature. And if the model is basing its decision on the confounding factor rather than the disease pattern itself, that's an issue of building trust. And second point here is that physicians these days, they provide information to their patients for joint decision making. They don't just dictate the treatment course to their patients. They explain the reasoning, and they come to a joint decision in modern medicine. And if we take that away, if the AI is dictating diagnosis and treatment plans, then we kind of move toward this paternalistic relationship between the AI physician and the patient, and this is something that would be a step back. And finally, even though AI is statistically more accurate than human doctors in a lot of areas these days, it can still rarely commit incomprehensible errors that would never be really committed by a human doctor. So if we're not able to fact check these and catch these because of a lack of explanations, then this creates some ethical issues where we are creating kind of adverse outcomes for a small but kind of significant portion of patients. Okay, so when we talk about interpretability, of course, we have to say that we cannot completely understand what a deep neural network is computing. So what I really mean in this talk when I say interpretability is post-hoc explanation methods. And these come in a few different types. The most common is visual attribution of the areas of the image that have higher influence in a model's decision. So I'm sure we're all familiar with class activation mapping, GradCam, saliency map, and these kinds of methods. So for instance, this image on the right shows a chest X-ray that was detected as being pneumonia positive. And the heat map, the areas in the red, are the areas that the model used most in coming up with its prediction. However, we sometimes want to go a step beyond that because this still doesn't tell us what it is computing in that area. So counterfactual explanations and concept-based explanations can help us move one more step towards an explanation. Okay, so when we have some explanation, a visual attribution or a saliency map, how do we know that the model is looking at the same areas as a radiologist would? So this is the first question I'm going to talk about. And I just want to begin this with a very brief overview of the types of attention maps we're going to examine. One of them is going to be from class activation mapping. I'm not going to explain this in detail to you. I'm assuming most of you are familiar with this, but after processing the image with some neural network, for instance, a convolutional neural network, we have some final spatial feature map, and then we get global activations by pooling for each activation map, and then for each class, these are combined linearly with some weights W. So we can come up with which areas of the image were most involved in the output for a particular class. Now, in these radiology images, typically this is a multi-label classification problem. So we are trying to detect if there's pneumonia in the image, but at the same time, we are trying to detect if there's pneumothorax in the image. So this brings up the question, like, well, we don't want to just look at the activation map for the winning class because we might have more than one. How do we combine them? One possibility is simply to just average the activation maps for the classes that are predicted to be present in that image. So that's the threshold one. If the logit for a particular class is positive, then we can include that in our final activation map. Or we can weight them with the sigmoid activations because this is binary classification. Or we could just add them all together without being any sort of weighting. So we're going to come back to this, but now I want to say a few words about how we went about comparing these activation maps to radiologists. So for this, you need some sort of ground truth. So this was some work funded by the NIH, and what we did is we collected this data set, which we called Reflex. So we had 5 board-certified forensic radiologists. We built an interface for them imitating clinical practice as much as possible. So what happens in this interface is we show them a chest X-ray, and we ask them to dictate their report as they would do in their practice. They speak into a microphone, and we are transcribing their dictation in real time. And at the same time, we're using the eye tracker to capture what they're looking at on the image. So both of these, both the eye tracking and the dictation come with timestamps, so we can align the two together. So the far right image on this page shows, for instance, the gaze, accumulated gaze of our radiologist looking at this chest X-ray on the left. The way we do this is we take the fixations given to us by the eye tracker, use their durations to come up with some Gaussians that are weighted with those durations and add them together to get a heat map. At the end of the reading, we also asked the radiologist to manually annotate using these ellipses and labels, disease labels associated with each ellipse. And we want to use that as a ground truth for evaluation or also for building baselines. So we selected randomly about 2,500 chest X-rays from the MIMIC CXR dataset. A small portion of these, like 110, were read by all 5 radiologists for assessing inter-rater agreement. The rest were read by 1 radiologist each. So compared to some of the previous work that was in this area, we built a bigger data set and using more than 1 radiologist. Okay, so now on to comparing the saliency maps with the radiologist case. So first thing I want to point out is if you look at an image of a radiologist gaze heat map built in the way I just mentioned to you, you notice several things. First of all, they search several areas in the lung and the heart in these X-rays for abnormalities. And there's a lot of inter-rater variability between radiologists. This is compared to AI model saliency map. which typically highlights only areas that have a higher chance of abnormality. So it lacks this search kind of pattern of the radiologists. So what metrics do we want to use in comparing? Well, normalized cross-correlation, of course, is a very reasonable one. So we can take the radiologist gaze and we can compute its normalized cross-correlation with the saliency map of our choice, for instance, from GradCam, and come up with some number. Another one is to come up with an area under the curve type of metric. For this, we can sample locations from the saliency map of the image, and we can see if the radiologist gaze at those locations is higher than locations that were sampled uniformly across the image. So this is another way of seeing how well the saliency map correlates with the radiologist gaze. So to get a better understanding of what kind of range of numbers we can expect with these metrics, we did a quick lower bound and upper bound kind of study. So the lower bound, we did a lung segmentation because all of the information related to pathologies that we are interested in here should be in the lung region of the image. So a lung segmentation, uniform distribution of saliency across the lung segmentation could be considered a lower bound as a saliency map. Now, as the upper bound, so we use those 100 or so images, we have multiple radiologists to compute inter-observer variability. So we can take one radiologist and compare it to the average of all the other radiologists as ground truth. So one thing that we noticed here is with the normalized cross-correlation metric, the lower bound is actually higher than the upper bound. So there's so much variability between the radiologists that each of them correlate better to the lung segmentation than each other in a way. So looking into this problem, looking at the literature, what we realized is this is because of what is called center bias. And so unlike natural images, there's a very strong center bias. There's a very strong tendency to look at very standard regions of the image. And this creates an issue. So to correct for this, what has been proposed in literature is to use these shuffled metrics. So for instance, for shuffled normalized cross-correlation, what you do is you take your normalized cross-correlation, but subtract from it the normalized cross-correlation of the same saliency map with the center bias. So in effect, you're trying to remove the correlation of the particular saliency map with the center bias and just trying to kind of leave how it correlates with the unexpected things in this particular chest X-ray, not the average things. And you can do the same with the AUC metric. So you can replace the uniform distribution with the center bias for the negative. So coming to our results for this part, so we tested several different types of networks with and without attention blocks in them. And we looked at the attention from these maps as a saliency. We also computed attention with GradCam, various versions of GradCam. I already mentioned the thresholded, the weighted, and the uniform. And it turned out that the uniform GradCam had the highest scores. So the shuffled normalized cross-correlations here were in the same level as inter-rater scores. The AUC scores were lower. And from this, what we can conclude is that saliency maps, so for instance, GradCam, are not good at highlighting areas fixated regularly in the average chest X-ray, but they are good at highlighting the specific areas in chest X-rays that radiologists fixate more than average. So that's good news, that GradCam is giving us something meaningful. What is maybe also worth noting here is that the uniform GradCam, which just combines all the class activation maps for the different classes without any sort of weighting, did the best. This might be due to kind of resembling maybe more the search pattern of the radiologist, because radiologists look at negative areas of the image as well as positive areas. And so something coming close to that, it's not surprising that it achieves maybe a better score. Okay, so the next thing we asked with this data set is, can we use this data set to move from an image classification type of model to an object detection type of model? So as I mentioned earlier, the labels with these chest X-rays usually come from mining the radiology reports, doing some text-based extraction on those reports. So this allows us to reach significant size of data sets. But when you talk about bounding boxes for pathologies, which are manually annotated by radiologists, then the data set sizes tend to be much smaller because this is costly to acquire. So the question we wanted to ask is, can the gaze data we collected, can it be aligned with the report and used instead of the manual annotations that we are typically using for supervising the training of models, right? Because if we can show that that is feasible, then this way of collecting data, the gaze data, could be adopted perhaps to the clinical practice without interrupting radiologist workflows. And then you can really scale it up. Now, I do have to say that, of course, at the moment, even though eye tracking is good, it does require calibration every so many cases. So this would be also dependent on that aspect getting better, which is not part of the research that we are doing. Okay, so how do we then take the report and eye tracking data and align them together to come up with some sort of supervision signal? So even though we have timestamps for both, unfortunately, radiologists don't talk about the pathology at the same time as they are looking at it. They typically observe, and then say something about it. Or if it's negative, they might not even say something about it. So what we did, we tried a bunch of heuristics rules, and this is the one we came up with. So we first take the report, we do some keyword extraction using the Checkspert labeler. So in this example here, for instance, ground glass and reticular opacities are the keywords that are found. And we found that, so to build the heat map, the radiologist gaze for this particular set of labels, the best is to consider the gaze during the sentence and the previous sentence, going back as far as 5 seconds if it's inside that previous sentence, or if the previous sentence starts before 5 seconds, then the mention of the sentence, we just stop at the beginning of the previous sentence. So we take the radiologist gaze in that frame and accumulate it using the Gaussians that we place at the fixations, and that becomes a heat map for this particular label. So then how do we use this in supervising a model? So let me just very quickly talk about this. So first of all, we chose a simple multi-resolution convolutional neural network backbone. So we have spatial activations at a couple of different layers that we take, and then we are trying to predict on a grid for each grid point whether that particular pathology is present there or not for the whole list of pathologies that we're interested in. So the way we supervise this is when we have some sort of manual annotation, for instance, as a ground truth, we can use that at each grid point for using cross entropy to supervise, or we can use the label-specific eye tracking I just mentioned. If nothing is available, which is for the rest of the mimic CXR dataset that we didn't include, we didn't have time to, of course, do this for the entire mimic CXR. We did it for like 2,500 images. For the rest of them, we use just a multiple instance learning type of scenario where if a pathology is present in the image, then one of the grid cells has to be positive. And to this, we add a regularization component, kind of modeling previous work by Karagris, and we take the spatial activations, upsample them using a URIA type of approach, and then try to predict the radiologist gaze. And this is used as a kind of a regularization. Okay, so doing this, so here are some results. So on the left, it's just the distribution of the different pathologies in our reflex data set. And then we have 3 models that we compare. So we have what we call the unannotated, but this is just the one that is only image level labels for the mimic CXR dataset. And then we have ours, which is the eye tracking model, using that to do the localization loss. And then we have what's called the ellipses. This is the manually annotated ellipses. So our radiologists prefer to annotate with ellipses rather than boxes. So we have manually annotated ellipses. So what we see is that, as expected, at the image level, the area under the curve at the image level is consistent across these 3 models. We don't really expect the localization losses to add much to image level prediction. But when you look at the intersection over union across the different models, so you see that, of course, the manual annotations provide a big boost over the annotated, over just the multiple instance learning. The eye tracking kind of falls somewhere in between. So it is definitely better than just using image level labels, but it's not as good as using manual annotations. Now, when we look at the breakdown across different pathologies, what we do realize is that For most pathologies, actually, eye tracking is pretty close to the manual annotations, except for the enlarged cardiac silhouette. So I'm going to talk about this, why this might be. For that one, it's actually doing kind of not so good at all. So here's a closer look at the different kinds of maps here and the different kinds of pathologies. So looking at maybe the bottom right first, pleural abnormality. So on the very left of that, we see the manual annotations, these two ellipses by the radiologists. We see the attention, the GradCam computer attention from a model or next to it, to its right, and it's kind of diffuse, kind of around the base of the lungs. Then a model that was trained by the ground truth, so using these types of annotations, and then the eye tracking model. So you can see that both of these, the manual annotation and eye tracking, are closer to the ground truth. This is the case for several other pathologies here, such as consolidation. When you look at enlarged cardiac silhouette, something interesting happens. So when you ask radiologists to manually annotate it, so they will, of course, include the entire heart, because this is a case of a heart that's too big, that's bigger than normal. But when you look at their eye tracking, they actually don't look at the whole heart to come up with this diagnosis. They'll look at just a few points on the silhouette of the heart, right? So if you train a model with that eye tracking, but then compare against the manual annotation, which includes the whole heart, it's not surprising that you get not so great numbers. The other thing to note maybe is like for smaller pathologies like fracture and pneumothorax, the localization model works worse than other ones. Okay, so this brings me to kind of this final part where I want to talk a little bit about counterfactuals and our work on that. So one of the criticisms that's typically, placed against saliency map type of explanations is that they're limited to a very narrow aspect of the computation, just the localization. It doesn't really tell you what it's computing, what the model is computing in that area. And this can be misleading. It can build a false sense of trust, people have argued. So there's this example, for instance, from a classic paper where showing a Siberian Husky, image of a Siberian Husky, and the saliency map computed for the Siberian Husky class, which is, as you would probably expect, is kind of centered on the face of the animal. But then if you evaluate the class attention map, activation map for a different class, like a flute, for instance, you get very similar saliency map. So that brings up the question, well, what is this really telling us? Can we do more than this? So this last bit of the talk is in the context of COPD. So this is a leading cause of death in the US, and it's a lung problem where your lungs are not functioning as they should, and typically diagnosed with pulmonary function tests where you exhale into this instrument, and two things are measured: the FEV, forced expiratory volume, in 1 second, and forced vital capacity. And based on the ratio of these two numbers, you are either okay or you're diagnosed with COPD. Now, we know evidence of COPD is present in chest x-rays, but not frequently highlighted by radiologists. So this is an opportunity for screening of chest x-rays. Some of the signals that you see in chest x-rays associated with COPD is like the flattening of the diaphragms, higher than normal lung volumes because of trapped air, and similarly, for the same reason, kind of more darkened type of lungs. And what we did is we collected at our institution some number of cases, about 5,000, which had PFTs within the 6 months of having the chest x-ray. And we used this data set to evaluate two things. Well, how often do the radiologists mention COPD evidence in their reports when looking at x-rays? And it was, as expected, it wasn't that much because it's not something they typically diagnosed from a chest x-ray. But if you build an image model on top of these chest x-rays, we use both the AP and the lateral views because it results in a better prediction accuracy in this case. So we show that there is much more evidence for COPD in these images than radiologists are actually reporting. But this brings us to the question, like, what is the evidence that the model is actually using? So to answer this, we took a counterfactual type of approach. And so this was before diffusion models, so we use adversarial training. So what we did is we train a pair generator and a predictive model where the the generator tries to come up with a modification to the image, which when added to the image will change it so that the predictive model, the regressor in this case, will get confused and change its decision, basically whether there's COPD or not, or what's the severity of the COPD in this. So I am not going to go through the losses one by one here, but it's the typical adversarial learning setup where the regressor tries to do the right thing and the generator is trying to basically move it in the opposite direction. Additionally, we have L1 type of regularization loss on the output of the generator because we wanted to make minimal changes, right? Counterfactuals are minimal perturbations to the image that change the decision. So when we did this, we found that actually this model is learning things that I just mentioned, for instance, the flatness of the diaphragm and the lung volumes and things like this. So the illustration on the bottom left here is where we have in the middle what we call original chest X-ray. That's the actual chest X-ray associated with some score for COPD, 0.72 in this case. And then we can push it to looking more normal towards the right, or looking like more COPD. And what we really do see in the different images is maybe more clear is the diaphragm position and the curvature changing. And you can see the normal images generated higher curvature of the diaphragm. Also, some darkening of the lungs or brightening of the lungs corresponding to the trapped air, and something about the shoulder position. So then we did a follow-up work on this because we thought some pathologies in chest X-rays probably are better modeled as geometric deformations, for instance, that diaphragm, rather than an additive kind of perturbation. So our generator now, instead of producing something that's added onto the image, produces a deformation vector, which is then used to transform the image geometrically, right? And we did this, and we kind of found a few other things that the model is looking at. Some of them expected, some of them not so expected. So saber-sheath trachea, this is indeed a sign of COPD, a secondary sign of COPD. And what it is that in the sagittal plane, the trachea is widened, but in the coronal plane, it's kind of narrowed. And if you look at the vectors here, the deformation vectors, this is indeed what's happening. The shoulder position was a surprise. So there is a difference in shoulder position, like in the clavicle height, between COPD patients and normals. And this we thought could be because of there's decreased shoulder mobility in COPD patients. So it could be hard to position them on a chest X-ray, or there's also osteoporosis that's associated with COPD. So it could be because of that. So whether this should be used as evidence in a model or not is debatable. So these two other ones are more examples of kind of confounders and the model getting confused. So one thing we saw is that the model is actually playing with the width of the chest, so the body mass index, if you will, of the patient, because COPD patients in kind of more severe cases will lose weight, so their BMI will be lower. So in trying to convert the image to looking like normal, the model actually tried to add weight by widening the chest. This is probably something that we don't like our models to use because this is a very non-specific thing. BMI is not specific to COPD at all, obviously. The final one here, the gastric bubble, this was interesting. So this sometimes, just below the diaphragm, you'll have gas, and it could look like a part of the lung, kind of leading the model to think perhaps that this is the lung that's too big and trying to collapse that gastric bubble to get rid of this false COPD finding in this case. So it shows that, using these counterfactuals, you can try to answer some of these questions. What is the model getting confused about? Is it using some confounders, or is it really using the evidence that's relevant to the disease? Okay, so let me conclude. So hopefully I made a case and got you maybe a little bit more excited about working on interpretability of AI in healthcare and radiology. Saliency maps, so GradChem type of saliency maps. The good news is that we found that this is approximately at the same level of variability when compared to radiologists as when you compare radiologists to each other. And we also tried it for training models. We found that it is not as good as manual annotations, but it is still worth something. But we have to kind of keep in mind that there's the potential of possibly scaling this by moving it into the clinical setting where you can get large data sets using eye tracking. So even though maybe one image annotated this way is not worth the same as manual annotations, you can perhaps get much larger numbers. And finally, counterfactuals can give more insight into AI models than just setting some maps. So using these together would be valuable, but of course, counterfactuals are still a bit harder to compute. So maybe better methods to compute these to provide a viable alternative would be important. So let me stop there. And if you have questions, I would be happy to try to answer that.
All right, fantastic. So I know that you do have a class that you need to get to, so I'll do a quick curation of a few of the questions that came in. So the first one is, do you think providing the localization in the radiograph is good enough for the interpretability of the model?
No, I don't think it is by itself good enough. I think it gets us part of the way there, but I don't think it's the full answer. So I think being able to say something about what is being computed in these areas that are highlighted in the localization is also important, because the model could be looking at the correct area, but using the wrong evidence there. It can be using maybe a confounder. So I think being able to point that out is important as well as the localization.
Another question, which is probably a little bit more general, in what ways do radiologists most often fail to correctly assess chest X-rays?
That is a question that maybe goes a little bit beyond my expertise, but we find that there's a large variability between them. That doesn't necessarily mean that they are wrong. So they might be looking at different areas of the image, but coming up with more or less similar conclusions. And one way that our study is a little different than clinical practice is, in clinical practice, they don't just get the chest X-ray or the radiology image. They also know about the clinical history of the patient. Somebody referred them to the radiologist with a particular question usually, so they're going to focus on that, and they are not going to have as much variability between them. What we did notice is that, like, depending on the experience level of the radiologist, sometimes maybe there's a difference in how likely they are to call out kind of these subtle, like not as obvious pathologies maybe. So confidence level, that might be a difference between them. But yeah, otherwise, what do they typically miss? That's a hard question to answer. I think there's been also other studies in psychology where when radiologists are fixating on a particular question asked to them to answer that question, they might miss other evidence. So like there is this study where they put an image of a little gorilla in part of the CT image, for instance, but the radiologist is not looking for that. They're looking for a particular evidence, and they completely miss and don't see that thing that doesn't belong in a chest X-ray or a CT image. So that might be one mode of failure, perhaps, like when they're looking for something particular, but there's something else there that's going on, that they might miss that.
All right, so we'll take two last questions. The next one is, have you considered using a mouse and having the radiologist explaining their decision as an alternative ground truth?
Sure. I mean, you can do this. Our motivation was to scale this up as a supervision, like providing labels for supervision, right? So we wanted a way of collecting localization data which did not interfere with the typical workflow of the radiologist. So something that we can eventually put in our clinical reading room and just gather data basically for free and scale to very large numbers. So you can get richer data if you're asking them to explain things and point it to the mouse, but you are going to be limited to, of course, smaller data set sizes. So that's a very, I think, viable direction to take, but that's not the direction we took. We wanted to show that maybe there's a way to collect data which can be scaled.
Fantastic. So we do have a bunch of other questions. I'll make sure to forward those along so we can get them answered offline. But one final question here is, why are we interested in the radiologist gaze at all if it's been seen that AI tends to outperform them?
Yeah, so that brings me back all the way to I guess maybe the first slide. So there are several reasons, and there are certainly arguments against this, right? Some people will argue that statistical accuracy is more than sufficient. The argument for interpretability, the ones that I tried to outline, is that first, unless we're taking clinicians out of the loop, which I don't see happening anytime soon, then it is important that they understand what the reasons behind the AI's prediction is, because they need to trust it. They need to catch errors if there is a potential error there. And they need to communicate this to their patients, right? So in modern medicine, when you go to a doctor, they don't just tell you okay, you need to have this surgery done, period, right? They tell you what they found and like what the different options are, and like then you weigh those with your own, what is important to you, and then there's this joint decision making, right? So we moved on from like this paternalistic model of medicine maybe a couple of 100 years ago. That wasn't like this. The doctor would just tell you what needs to be done and just do it. But so it would be a step backwards in that sense if we are just dictating things to patients and not explaining at all. So that's what I would say.